Hi, everyone. Welcome to another episode of Princess and the Pod. I am your host, Yvette, and today we have a very special guest, Dr. Yoon. He is a board certified medical anesthesiologist that's based out of California. And I'm so glad to have Dr. Yoon on the pod. We've chatted a lot back and forth on Instagram. You were actually previously my husband also is now no longer part of that group, but you guys were part of the same anesthesiology group here in San Diego. I think you still do a little bit of cases out here in San Diego. But we connected on social, and I'm so glad to have you on the podcast because it's rare that we really truly get to collaborate with medicine and dentistry. And I think you're mostly dentistry based as far as anesthesia goes, yeah?
Right, and you bring up a really good point. There really isn't that much of a bridge or communication between the
Mm,
medical and dental arenas, which is really unfortunate
I know.
because, as you know, more and more of our medical health is so closely tied to our dental health and hygiene. And I think, in general, dentists do so much of a better job of learning about medicine and knowing how medical issues affect dentistry. On the other hand, I am shocked sometimes by how little we as physicians understand and know about dental health and oral hygiene. Our education in those aspects is really lacking.
It's really wild. So my husband's a physician, as you know, you're both in the same specialty. He knows teeth numbers, obviously now through us being married and through our friends, and now that we get to collaborate. But I think I'm in that special niche where I'm around a lot of physicians and they get to see what I do and how intertwined like perio and heart disease, Alzheimer's, lung disease is, but unfortunately we're separated during, medical school and dental school. So it's interesting. So tell us a little bit about yourself, where you went to college, med school, how you got interested in anesthesia, and then how you ended up in dentistry.
Sure. So I'm originally from Wisconsin, believe it or not, and grew up in Milwaukee. So I went to my undergrad at the University of Wisconsin-Madison and then met my wife who's from Orange County. And for some reason, she didn't want to live back in the Midwest. So I came out to California and trained and received my medical degree from University of Southern California, and then jumped across town and did my residency at UCLA Medical Center. Like most medical anesthesiologists, when I first graduated, I did mostly hospital-based anesthesia cases, and then slowly migrated to the outpatient surgery center type of anesthesia. And then I almost fell into dental anesthesia by accident. Um, I had a couple of colleagues, physicians who started a mobile dental anesthesia practice. And I remember, watching them one time set up for a case. And I thought to myself, there's no way I'm ever going to do this. You guys are crazy. Why would you ever leave the safe cocoon of the hospital? It's the wild, wild west. You're completely alone. And so I resisted for a long time. But fortunately, they were persistent and they eventually got me interested and through the learning curve. I like to say that the anesthesia for dental sedation is fairly straightforward,
Right.
but it's the environment that's so difficult, and to be honest, most of my medical colleagues have a very difficult time with the idea of transitioning to an environment where you're completely isolated, you're on your own, and you're working in a foreign environment like a dental office. So even though most medical anesthesiologists have no problems in terms of the anesthesia, the medical aspects of the case, just logistically trying to bring all the equipment and be able to be a one-man show and be able to do everything safely and smoothly is very, very difficult. But, you know, um, so be it. It's now what I pretty much have done full time for the last 15 years. And with that, my participation and involvement with the dental arena has grown. So I've become a member of the board for the UCLA Dental School. I'm an expert consultant for the Dental Board of California, which ties into my work as a malpractice expert witness, where I see a lot of these dental sedation disasters, unfortunately, and and able to do some closed claims analysis and root cause analysis as to why some of these horrible cases occur. And even my daughter now has taken my advice. She originally started off on the medical tract, and I convinced her, why don't you move over to the dental tract? So she actually is in her final year of dental school at Loma Linda as well. So as a medical physician, I think I have very strong ties to the dental community.
No, you do. You have really strong ties, and I appreciate it. Yeah, we both work for the board, do some expert witness. So it's interesting because not a lot of our colleagues do that, but every time that I sit with my husband and our friends that are in the medical field as far as anesthesia goes, I'm like, we need more anesthesiologists. You guys come, I will
Yeah.
set it up. And as soon as they hear anything, it's like, no, absolutely not. I'm
Yes.
not doing this. There's so much that's out of your control. The lab work, the patients,
Right.
you're just going in kind of blind unless you have a really office that's set up and you've been working with them for a long time and they have the flow that you need. It's so tough.
Right. In fact, so one of the best things I've done is we have hired our own patient coordinator for our
Mm.
practice that
Hmm.
does all the legwork because you're right. That is one of the most significant obstacles. In the hospital, as a physician, everything is sort of done for you. The labs
Hmm.
are there, the workup is there. But in the dental office, oftentimes these patients are coming with very little physician follow-up, no labs. And so we're having to play detective and do a lot of investigative work before we can even accept the case.
Yeah.
And so we're really fortunate with our group to have our own patient coordinator that does a lot of that legwork for us so that we can make sure we know these patients in detail before we even administer a medicine to them.
It's tough, right? And a lot of times you're hopping on the phone with the patient directly, which in the hospital you would never do. Especially as an anesthesiologist, we joke that
Exactly.
the patient doesn't really remember their anesthesiologist unless it was an epidural or something. And it's just like, okay, goodbye, good night. But now in dentistry, you're the face of this patient's procedure and you're calling them your coordinator and you're getting all this lab work and it's so different than traditional medicine, if you will.
Right. I mean, the few times I've made house calls in my career has
Definitely.
been for dental cases. I
Yeah,
have to do the preoperative evaluation, and then I realize, there's only so much I can glean from
right.
talking to the patient. I have to actually go see them at their home
Yeah.
and see,
Mhm.
how many stairs they have up to their house and
Yeah.
what their living situation is like. Are they going to be safe after the procedure? Take a look at them physically and do a physical exam. So, yeah, I still do house calls. And exactly. Yeah, exactly.
It's tough. Well, thank you. I appreciate you. Yeah. So let's talk a little bit about the invisible gorilla. What do you mean by the invisible gorilla?
Right. So I lecture extensively across the country to dental groups, DSOs, about patient safety. And one of the common themes in my discussions is the concept of the invisible gorilla, which is based on this classic Harvard University experiment where they took Harvard students, right? So really smart college kids, put them in an experiment where they have to count the number of times a basketball is being passed by members of a team dressed in white. At the same time, there's a team dressed in black and they're passing around the basketball. So as you're trying to count the number of times the basketball is being passed, a person in the gorilla suit will literally walk into the middle of the room, wave their arm, and then walk off. So, I mean, an obvious intrusion, right?
Right.
But despite how obvious this intrusion is, time after time again, it doesn't matter if it's Harvard students, it doesn't matter if it's in a third world country, first world country, whatever your socioeconomic status, consistently, at least half of the audience will never see the gorilla. And so the point behind this experiment is that our brains fool us all the time. And so when it
Mm.
comes to patient safety, whether it's sedation safety, ignoring an alarm, or whether it's waterline safety or dental sterilization safety, how many times do we not see that invisible gorilla, which is a real threat to our patients, and instead focus on some other distraction or some other problem? And I can tell you, as an expert witness in malpractice cases, Having viewed, hundreds of cases over the last 25 years for the Dental Board of California and for lawyers, that's a common theme that comes up over and over again is that doctors, it doesn't matter how smart you are. This is not
Right.
a question of intelligence. It's something that we all have as part of our human frailty. We're all prone to the invisible gorilla phenomenon. And so that's why it's really important to be aware of that and to be aware of that blind spot and to make sure that you take, purposeful strategies to try to combat the invisible gorilla, which includes training your entire team to be your eyes and ears and setting up protocols and checklists to make sure that some of these obvious mistakes or intrusions don't get ignored or overlooked.
It's so tough, right? Even like with myself, I do a lot of IV sedation daily with Versed, which is completely reversible. I know the time length, I know the working time. I feel very comfortable with Versed. I've still had emergencies. I've still had a patient's BP spike or something happens, or you want to make sure the bag is okay, there's no bubbles in the bag, or there's so many things. And this is moderate sedation. So I can't imagine doing both like general anesthesia and dentistry. There's just so much to focus on. Plus, no matter what, I can close the door, I can still hear the front desk, and it's still stressing me out because it's
Right.
my business and it's my practice. And the door, somebody banged on the door today, was the mail guy, but there's just so much going on in the practice and it's really hard to do everything. I didn't get to see you when you popped in, but you dropped off your medical emergency book. Thank you so much. It's so important that we do emergency training. We're supposed to do it monthly in the state of California, every month, because also think about it, after COVID, we've lost a lot of team members, a lot of dental offices are having shifts in team members, or maybe like in my office, as we're getting momentum, some team members work some days, others work other days. It's really hard to collaborate, but even your medical emergency book, which you lecture on a lot, it's so thorough, and it must have taken a lot of time to put that together. But you're so passionate about it, but not in a, you're not condescending. You're very much like, we're all here to learn. We're all professionals. Let's help our patients, right?
Yeah. Well, yeah, thank you for that feedback. And by the way, if anyone in your audience wants a copy
Yeah.
of that medical emergency manual, I'm happy to email them a copy. They can just
Okay.
email me and I'd be happy to send one out. And
All
I guess we
right.
can include our email later. But that brings
Thank
up an
you.
important
Yeah.
point because, again, like I said at the beginning, I'm so impressed by how much medicine that dentists know and how much effort they make into making sure they're up to date as much as possible on medical issues that affect especially their dental practice.
Mhm.
Conversely, we as physicians do very little to understand dental pathology and the
Yeah.
way our oral health affects our physical health. So yeah, we as physicians, as the medical community, have a long way to go. But no, it's really been my honor to work with dental offices. I'm just so impressed because whenever I do a medical emergency lecture or workshop, I always say, I can't teach you anything about dentistry. I'm not going to be able to teach you anything sexy or lucrative
Right.
about implants. All I can teach you about is medical emergencies that if and when they occur, you may be able to save your patient's life. And yet my lectures are always well attended, well received,
Hmm.
and that's really a reflection of the audience as to their own personal responsibility that the people and doctors and dental assistants take to make sure that they're not just up to date on dental issues, but medical issues as well.
Yeah, I've been to your lectures. You're a very dynamic speaker. So let's talk a little bit about not quite like expert review, but medical emergencies in the dental office. What's the most common medical emergency? And obviously, dentists want to learn. We want to improve. How can we improve? Maybe just a little bit.
Sure. Well, obviously, the most common medical emergency that we see in dental offices is by far syncope. And 99.99% of the time, it's a benign phenomenon. We've all seen it in our practices where a healthy person, sees the sight of the needle or sees
Mhm.
some blood and then suddenly faints. One caveat, though, with syncope, which is fairly easily managed, simply by observation and common sense. One of the things that, as Health First, which I'm a medical advisory board member and provides a lot of the medical emergency kits for dental offices, one of the things that we have gone away from and we no longer recommend is the use of the ammonia inhalants. Where
Ah,
those
mm-hmm.
tabs that you break off
The salts.
to
Yeah,
try to
yeah.
wake up a patient. Yeah, if you have a case of what looks like benign syncope, otherwise healthy patient. And yeah, maybe they're a little bit slow to wake up, but they're otherwise stable. I would urge you to reconsider, breaking that ammonia inhalant just to wake them up. And why is that? Well, one of the reasons is it can cause a violent reaction where the
Mm,
patient can actually jerk their head or hit their head and cause physical trauma to their head. The second reason is that there have been case reports of severe bronchospasm after the inhalation of the ammonia inhalant. So you took what was, a fairly benign emergency, syncope,
right.
and now you have a life-threatening emergency, severe bronchospasm or even head trauma. So I think more and more societies are going away from that recommendation of using ammonia inhalants. And so I would really be cautious, before I would, tell someone to break open an ammonia inhalant to try to wake the patient up. 99.99% of the time, syncope is benign and will resolve on its own with no further treatment.
That's really interesting. I haven't had a syncope case in so long. So but I definitely have they're not salts, but the little tellets taped to my microscope right next
Yes,
to the chair. But yeah, once you get into bronchospasms, laryngospasms, then you're dealing with a whole other medical
right,
emergency.
exactly.
Yeah. So, what do you do to assess the patient if it's, syncope or maybe something more serious? Are you listening for breathing, checking pulse? What are you doing if that's what you suspect?
Right. So that's a great question. So obviously common sense applies and all the ABCs that you have been taught apply in this situation. So obviously you're going to stop treatment, observe the patient, ideally place them on their side, assess their airway, their breathing and circulation. I don't think, the majority of the time it's necessary to even, measure the blood pressure or the pulse oximeter, but certainly that's not a harmful thing to do. It's not a bad idea. I just don't think it's necessary for the most of these benign cases where there's an obvious history of a trigger. The things that we want to look for obviously are irregular breathing, any form of seizure-like activity. Be more vigilant in patients who have medical histories such as cardiovascular disease, um, uh, neurologic disease. I have a much higher index of suspicion that there may be a more malignant cause of the syncope in those types of cases. In cases where there is no obvious trigger, let's say you have a patient and for no reason at all, you haven't shown him any needle, you haven't been exposed to any blood, they faint for no reason. Again, probably benign syncope, but I'm going to have a much more higher index of suspicion that there may be a more malignant cause. And the more malignant causes that we're worried about are obviously neurological events, strokes,
Right.
cardiovascular accidents, cardiac events. Was there sudden cardiac arrhythmia? And so that's where it's helpful to assess the pulse and the circulation. And then, if there's any sort of tongue biting, any urinary incontinence, to me, that's an automatic call to just, be on the safe side and activate the EMS system to make sure that this is not a more malignant cause of the syncope.
That makes sense. Do you usually recommend calling 911 for syncope or if it's benign?
Yeah. So again, that depends on your own individual judgment and what you're
Hmm.
comfortable with. Um, I like what one malpractice lawyer told me. He goes, Steve, no one has ever been sued in dental malpractice for
Sure.
calling 911 early.
Right.
They
Right.
certainly have been sued for not calling 911 uh, in a prompt manner. But I think, Dr. Malamud's rule, I think, applies is that if you are getting uncomfortable with the situation, then call 911 and activate the
Okay.
EMS system. It probably just is benign syncope, but if you personally are uncomfortable with the situation, then that's a good clue for you to call 911. On the other hand, I see all sorts of emergencies, almost every week in my practice, most of them minor. I'm very, very comfortable, with laryngospasm, with even bronchospasm and other emergencies. And so it takes a while for me to get uncomfortable to the point where I would even think about calling 911. But that's me,
Yeah.
and my personal and professional perspective. If you're a GP dentist and you're not comfortable, then by all means, activate EMS sooner rather than later.
Yeah, I've heard the same thing from doing like expert or consulting. It's that they failed to call 911 soon enough. So I think that's a
Exactly.
big take home message is if you don't feel comfortable, call 911.
Right. Exactly.
Yeah. Okay, so let's hop on to snow and sedation.
Yeah.
Tell us
So
about it.
thank you for mentioning that. So we're really excited. This will be our second year next February in 2026, but we have world-class lecturers from Greece, Australia, from around the country, and who are all talking about topics related to dental sedation. And the course co-directors are myself, and then also one of the leading pediatric anesthesiologists in the world, Dr. Karen Mason from Harvard University. She actually has the textbook on pediatric sedation outside the OR. And for years, she did a pediatric sedation outside the OR conference, which focused mostly on dental sedation. We've now transformed that into a Park City venue where we can ski and snowboard, have fun on the slopes, but at the same time get a lot of valuable CE related dental sedation. So we would love to have your doctors come as well. It'll be next President's Day weekend and week in February 2026 in Park City at the Sundial Lodge, which is a ski in, ski out resort. And for more information, you can go to www.snowandsedation.com. So snowandsedation.com, and you'll find the registration information there as well as the tentative course schedule as well.
Awesome. I will link it down below for everybody as well as your email. So if people want that emergency handbook, they can find a way to reach you. Anything else before we go? I know you're super
Yeah,
busy, probably
yeah,
tired. You're working all over the place. So
yeah. So the other thing I want to talk about just very briefly, medical
yeah.
emergency wise, the most common medical emergency I see lacking in dental offices that I go to is the emergency oxygen cylinder. Okay. In my opinion, oxygen is one of the most important emergency medications that every dental office should have. And that's because almost every dental office, except for maybe orthodontics, every dental office uses a medicine called local anesthesia with epinephrine.
Mhm.
And if you look at the manufacturer's instructions that come with every cartridge of local anesthesia with epinephrine, it'll tell you not once, but 5 times that if you administer this medication, you have to have the capability to deliver positive pressure ventilation, ideally with an ambu bag with 100% oxygen. So every dental office should have an emergency oxygen cylinder. And yet many offices I go to do not even have a cylinder, or if they have a cylinder, they got it, haven't checked in years, and the cylinder's empty or the regulator's not working. So, if nothing else tonight, my take home message is go back tomorrow to your office and make sure that you check your emergency oxygen cylinder on a regular basis. Make sure it's full, make sure everyone knows where it is and how to use it. Um, because, it can and does occur where people will go into cardiac arrest simply from the injection of local anesthesia with epinephrine. I can give you numerous cases. So every dental office should be prepared for that possibility.
That is so wild to me. And it's little things like we were discussing systems in the office, right? So even within my office, which I feel like we have really strong, solid systems, every once in a while somebody will forget to rip off the tag where it says in use or when it's empty, putting it back.
Right,
Even something minor like that, if you knock over an oxygen tank that is full, we're in a different kind of emergency, right?
right.
It's a
Yeah,
torpedo in the office.
right. I mean, it can, and much more often, it damages the regulator.
Mm,
And so now you have the emergency oxygen cylinder that's full, but you have a regulator that's broken or malfunctioning now. And if you don't
you
test it, you
can't
won't
use
know.
it.
It's that invisible gorilla that we talked about. You have an
Yeah.
obvious error in front of you, but you won't see it.
And you can't use it, and who knows how to use it? Who's the designated person? Who's the person that's checking the tank? Especially if you're not doing nitrous or,
Exactly.
mod sed, or I feel like even with like slight sedation, we should still be checking patients' pulse
Yeah.
ox and oxygen levels and, their blood pressure and everything. But that's really interesting. But you're going into everybody's office and you're probably bringing your own oxygen in,
Right.
right? Hmm.
Right. So that's one of the biggest challenges as a mobile
Traveling with you.
anesthesiologist is making sure that the most important medication, which is oxygen, is immediately available. And
Yeah.
yeah, I can tell you all sorts of crazy horror stories over the years where
Oh,
oxygen systems have failed in the office, even
no.
plumb lines have failed. And so you have to be prepared for Murphy's Law and be able to think fast on your feet and be able to find solutions to these kinds of issues, which for the most part never happen in the hospital, right?
Right.
You never have to
Because
worry
you
about it
have
in the
people you
hospital.
can call, you have
Yeah,
maintenance, you can call, like, hey, you
right.
can pause. But no, you're
Yeah,
the person, you're the maintenance person, or
exactly.
you're the person checking the lines, and you're the person checking the
Right.
plumbing and
You're
everything.
right. Exactly. Yeah. So we come up with our own
Oh,
tricks as to
yeah.
how to make sure we have reliable oxygen at all times.
Do you think that's why a lot of medical anesthesiologists don't want to do dental?
Oh,
Because,
yeah, absolutely. Yeah.
yeah.
That's one of the biggest factors is that all the things that you take for granted in a hospital setting,
Yeah.
you cannot take for granted in the dental office, right?
Mm, it's
Yeah, things will break, things will malfunction. In the
right.
hospital, not a big deal. In the dental office, it can become a disaster.
But you're trained, like in residency, they'll come, like, snip the lines, do something, see if you notice what's wrong with the equipment. So, like, and I feel like in dentistry, most of the patients are well patients, ASA one, maybe two. They're outpatient surgery patients, right? Versus like, you
Well,
don't know
that
what
that
you're gonna
no,
get.
no, that
No,
that used to be true, but
no.
one of the biggest trends we're seeing, obviously, as you know, is the all on four.
Right.
Right?
Yeah, yeah,
And
yeah.
so I've learned that if you are at the point in your life where you need an all-in-four, where we need to rip out all your teeth
Right.
and give you implants, what does that say about your cardiovascular and metabolic health?
Hmm. Hmm.
And I don't want to go into too much detail because these are still cases pending, but I cannot
Right.
tell you how many deaths I have on my desk right now
Yeah.
from patients who have died during or just after an all-on-four procedure. And sometimes it was due to negligence, sometimes it
Right.
wasn't, sometimes these were just sick patients. But boy, we are seeing a lot of very, very sick patients who,
Yeah.
uh, who for whatever reason have ignored their health. But boy, when it comes to the time when they can't eat,
Right.
everything else goes out the window. I'm going to get new teeth, no matter
Right.
what. And so yeah, we have to be very careful in dental anesthesia because of the new technology and the procedures being performed. We're doing really complex hospital procedures,
Right.
even with robots, right? The Yomi robot
Right.
in dental offices without the benefits, with all the benefits of a hospital system. So we have to be
Right.
very careful.
Right. It's interesting. So, I same thing. I don't want to comment too much, but on some of the cases that I've done expert for, they're usually all on four. Whatever the complication is, it's just, but when things go, it sounds great. You get teeth in a day, you got your new
Right,
dentures, we're gonna do this and that, but it's my job is to save your natural teeth. My last resort is doing dental implants because they're so complex, they're so complicated. When they fail, when something goes wrong, it's a life-threatening issue, right? To
right,
me,
right,
that's how
right.
I feel about it. And I think you and I have seen enough cases where we feel the same. But part of me makes me feel like, should we be doing these cases in the hospital? And maybe eventually we'll develop a protocol where you're in the hospital for the following 2 to 3 days after that. Same thing with orthodontic surgery, which I'm sure you've done a ton of
Right.
orthodontic cases. I had BSSO, lower BSSO, and a genioplasty when I was like 18.
Yeah.
with a great OMFS surgeon. We did it at the hospital. I stayed at the hospital for 2 to 3 days,
Right.
but it was an extensive surgery. So
Sure.
I feel like All on Four is comparable, if not more aggressive than Lefort or BSSO, because you're extracting a lot of teeth. There's so much blood loss. There's a lot of arteries, nerves, veins, everything. And
Yeah.
we're doing this as outpatient surgery, and it's on the patient to take care of themselves or their family
Yeah.
member or somebody. And how did we get in this position in the first place that you need all your teeth extracted, which is
Yeah.
also sad and tough, you know?
Yeah. I mean, that's a whole nother podcast, right?
Yeah.
Yeah. But yeah, you bring up some really good points, financially and logistically, it's just so hard to get dental procedures scheduled in the
Mhm.
hospital. So, but boy, yeah, that would be ideal for some patients, because we see some severely ASA3 patients, who want the all on four, and boy,
Yeah.
yeah, in a hospital setting,
Yeah.
probably would be ideal for them in some cases.
You still work in the hospital a little bit,
Yes,
right? You're at
yeah, I just
Rady's a bit?
you're right. I'm a staff at Rady's Hospital in San Diego, and then also my primary hospital, Saddleback Memorial in Orange County.
Mhm.
But to be honest, I only do maybe a couple of medical days a year, simply because it's hard to keep up with the demand on the dental side. I'm fortunate to be part of the largest group of anesthesiologists servicing dental offices in Southern California. There's currently about 18 or 19 of us. So
Wow.
we're, fairly large. In
Big
fact, we are
group.
the largest group in Southern California. But boy, it's still hard for us to keep up with the demand.
Yeah.
Yeah, because there's so few that do this.
Like, take my husband, get him
Yeah,
out of
I would love
medicine.
to.
Take my
Tell him to talk,
husband.
call, yeah, call me and we'll talk, and I'll break him in and get him over the learning curve. Yeah.
Oh my
But
gosh,
it's
there's
daunting though.
so
It's
many
daunting.
times where I'm like, we can do this. And they're like, no.
Yeah. Yeah. And
I,
and that's the reaction I
yeah.
get from probably like 98% of my colleagues in the medical side, is that they're intrigued by it, but then once they find out what's involved, they're like, okay, no, no thanks. Yeah, which is unfortunate because it really it's been a wonderful aspect to my career. I'm so glad I went into this niche and really enjoyed it.
We need you guys. And I think there's one or two schools that are dentist anesthesiologists. Maybe UCLA still has their school. I know Loma Linda's on pause for now. Maybe NYU has a program. So, as far as on the dental side, it's not getting any better. So, it has to
No,
come from MDs. And
right, right.
yeah, we definitely we need to collaborate for sure.
Yeah. Yeah, there's
It's
only
tough.
6 programs east of the Mississippi, four of
Okay.
them on New York City, I think. And there were no programs west of the Mississippi after Loma Linda closed down. In fact,
Yeah.
one of the last graduates from Loma Linda is one of my partners,
Who?
Dr. Janice Chen.
Okay.
But then UNLV just started a dentist
Okay.
anesthesiology program. So that's the first program west of the Mississippi, in several years. But still, I mean, that's 7 programs that are training maybe 2, maybe 3
Right.
residents a year. I mean, yeah, it's a drop in
Right.
the bucket.
Yeah, it's tough. And then I it's tough for them to get integrated into medical school and to get the training. So there's just yeah, there's a big gap. But
Yeah,
you got a long road ahead, and thank you for, paving the way and starting this. I really appreciate it.
great. Well, thank you very much.
Yes, I thank you for hopping on the podcast. Before we go, we have Snow and Sedation. I will link your bio down below for anybody that wants your manual or to get in touch with you. I know you're busy lecturing, speaking, working. You got a daughter that's busy in dental school. I can't wait to meet her one day, hopefully. And then we had some take home pearls for the audience, but anything else you want? The
No, no, thank you very much.
podcasters.
And yeah, no, happy to help. And yeah, so if anyone in the audience has any further questions, just shoot me an email, and I respond usually very quickly.
You do. I know. I'm like you're not that far from a traditional anesthesiologist. You're always on your phone.
Yeah, exactly.
Okay, I'm gonna close it down, Doc. Just stay
Okay,
on.
great. Thanks very
Okay.
much. Okay, have a
Thank you.
good night.
Wait. No, Stan. Wait.